Welcome everyone to our webinar partnering with GWEPs, Geriatric Workforce Enhancement Programs, and Dementia Caregiving and Education, Opportunities for Public Health. I'm Joe Gogler. I'll be moderating and hosting this webinar today. We'll start in a minute or so so everyone joins us and gets settled. Thank you so much. We're going to start in a minute, everyone. I'm just waiting for everyone to get settled and join on the Zoom. We'll stay one more minute or so, if not, if at the most. All right, welcome everyone to our webinar today, partnering with Geriatric Workforce Enhancement Programs, or GWEPs, and Dementia Caregiving and Education, Opportunities for Public Health. We are very excited to be jointly sponsoring this very special webinar vis-a-vis the BOLD, Building Our Largest Dementia Infrastructure, Public Health Center of Excellence on Dementia Caregiving, as well as the American Geriatric Society. So thank you for joining us today. Next slide, please. I'm Joe Gogler. I direct the BOLD, Public Health Center of Excellence on Dementia Caregiving, but also I am part of the leadership team of the Minnesota North Star Geriatric Workforce Enhancement Program, which is housed here at the University of Minnesota as well. So I have two hats here, and we are very excited to think about and actually provide you with some stellar examples of how GWEPs and BOLD recipients, both the national centers as well as the state programs, as well as departments of health in general, can be really fruitful partners in work that often aligns very closely. So, and that's really the whole premise of our webinar today. Next slide, please. I'd very much like to begin with a land acknowledgement of the University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values of courage, wisdom, respect, and generosity. Thank you. Next slide. So really briefly, the BOLD Public Health Center of Excellence is one of three national centers supported by the BOLD Act and overseen by the Centers of Disease Control, which we'll be hearing more about shortly. And our particular center focuses on dementia caregiving from a public health standpoint. And specifically, the PICO, which we call for short, is designed to support public health agencies, whether they be state, tribal, or even local agencies, to really help them develop their dementia caregiving focused initiatives. And how we do that is really in three ways. First, we try to improve access and knowledge about evidence-based programs and best practices that support those who care for individuals living with dementia, and specifically those who provide unpaid care, most often relatives, friends, other acquaintances that offer this essential, crucial assistance to people living with dementia across the U.S. Second, we're very interested in facilitating connections and collaborations amongst not just public health agencies themselves, but others as well. And you kind of are seeing that embodied in this webinar today to really, number one, elevate dementia and dementia caregiving as a public health priority. And then number two, figuring out how we can work together to address what we think is a critical public health issue, as well as opportunity in our communities, our states, and across the U.S. as well. And then finally, we provide direct technical assistance for helping agencies, public health and otherwise, identify, implement, and select public health interventions or other strategies to best support dementia caregivers. And again, we encourage you to scan the QR code here to visit our website. Easy to remember, bolddementiacaregiving.org. Next slide, please. So we also, and I also wanted to talk about another key element of our work here at Minnesota, but also a partnership that's in place, which is with, as I mentioned before, the Minnesota North Star Geriatrics Workforce Enhancement Program. And the Minnesota GWEP is really designed and focused on improving the healthcare and health of older adults across the entire state. It's a 5-year project graciously funded by the Health Resources and Services Administration. And the goal is really to facilitate and strengthen meaningful support and collaboration across a whole range of partners in the space of geriatrics, and particularly approaching geriatrics from very much an interdisciplinary, interprofessional perspective in terms of education, in terms of developing promising care models, age-friendly health systems, and direct support and education. And as you can see here, the 3 main objectives of our GWEP, and I would imagine it all is similar across many of the GWEPs, including the ones you'll hear about today. Our goals are really to provide greater access to community education in aging and dementia, improve geriatrics training in health professions, and really transform primary care to be more age-friendly care. And so, again, you can already see there are definite points of alignment between the goals of the BOLD initiative and the goals of the many GWEPs that are currently doing very important work across the country. Next slide, please. So we very much value your feedback. Quick logistical note, at the end of the survey, we would like you to, or at the end of the webinar, pardon me, we'd very much like you to complete a survey to offer us feedback. If you have a chance, please scan this QR code on your phone to open the survey on your phone, or you can click the link in the chat, which is just being provided here by Alma Johnson. And again, we encourage you to please complete the survey because it really helps us direct future offerings. Next slide. Well, I'm going to be turning it over to a tremendous panel here today that is really going to talk about the points of interface and collaboration, as well as opportunities that exist between BOLD and Departments of Health and BOLD recipients and GWEPs. And included in our panel are Dr. Naina Tomosa, who's a Senior Public Health Analyst of Geriatrics in Health Resources and Services Administration, the Division of Medicine and Dentistry and Medical Education and Geriatrics. Then representing the CDC, we have Dr. Lisa McGuire, who leads the Alzheimer's Disease Science Team in the Healthy Aging Branch Division of Population Health in CDC. And then we have 2 very exciting exemplars. First, from the state of Rhode Island, we have Victoria Parker, who's a manager of Alzheimer's disease and related disorder programs in the Rhode Island Department of Health. And then Faith Helm, who's a project manager at the Rhode Island Geriatric Education Center at the University of Rhode Island. And she is involved with their GWEP there. And then we have Dr. Ted Johnson, Division Director of General Medicine at Emory, and is also in the School of Medicine and is the Program Director of the Emory GWEP. And then Elizabeth Head, who's representing the Georgia Department of Public Health, of course, in the state of Georgia. So without further ado, I'd like to turn it over to Dr. Tomosa. Thanks for joining us today, and very excited to hear and learn more about how GWEPs and Departments of Health can collaborate in exciting ways.
Great. Thank you, Dr. Gagla. I want to wish everybody a good day and thank our hosts for inviting me and putting for all the trouble to come to this wonderful meeting of great people. And I think you're going to learn it's going to be a very valuable discussion, I think, for all of us. I'm putting myself in there too. I hope to learn a great deal as well. What I want to talk to you about today is what is a geriatric workforce enhancement program, and why is it going to be useful for you to know more about them. Next slide, please. This is my agenda for the day. Next slide, please. We're always okay. Fine. HRSA, Health Resources and Services Administration, is always working to improve the healthcare workforce. We all know that there's a growing demand, there's a shrinking supply, and there's an unequal distribution. On the next slide, we talk about the division. Next slide, please. The Bureau of Health Workforce, which has a mission. Okay, great. I'll go right to the GWEPs. This will be just fine. The purpose of the GWEPs is to improve health outcomes for older adults by developing a healthcare workforce that maximizes patient and family engagement, and by integrating geriatrics in primary care. Next slide, please. The goals are to educate and train the primary care and geriatrics workforces to care for older adults across the continuum of care, including in nursing homes, and also to partner with community-based organizations, including departments of health, to address gaps in healthcare for older adults, to promote age-friendly health systems and dementia-friendly communities, and to address the social determinants of health. Let's see how we did this in the next slide. Okay. I think that we're okay. So what does a GWEP do exactly? Well, as you can see at this infographic, we concentrate on patient-centered care for patients, families, and caregivers. Without patients, families, and caregivers, there would be no need for GWEPs. But because we have all of those, there is a need. We do concentrate on training and education. We do workforce training that is community-based and interprofessional. We support clinical training environments where we ask that there's an integration of geriatrics and primary care. There's the age-friendly health systems that we just discussed, as well as dementia-friendly communities. And how do we do this? We do this through what we call reciprocal partnerships. That means that every GWEP has academic partners. It has partners that are in primary care systems or sites. And we also have community-based organizations. Now, I'd like to give you some numbers on all of that, if I could, on the next slide. We have a number of current grantees. They are in the 5th year, as Joe indicated earlier, 5th and final year. And we'll get to that at the end of what I have to say. Currently, we have 29 states and territories that have one GWEP each. And then we have another 8 states that have at least 2 GWEPs. So the next slide shows the geographic distribution of these across the United States. And we think we've done a pretty good job. It's not ideal, but we range from Puerto Rico to Maine to Washington to Guam. So as you can see, we have done, and in many states all in between as well, as you can see. Many of our GWEPs concentrate on the underserved, and many are on rural and underserved. So next slide, please. So I'm going to basically end this with a bunch of numbers for you, because I want to talk to you about how well our current GWEPs are doing with their reciprocal partnerships. So when the original applications came in, the 48 grant recipients had 174 academic partners, and that included 1 school of public health that holds the GWEP itself, and also 4 partnering schools of public health. And then 391 primary care partners and 284 community organizations. 4 years later, we checked those numbers again, and we found that all of these numbers increased. We doubled the number of academic partners and primary care partners, and almost doubled the number of community organizations. We've gone from 1 grant holder and 4 partnering schools of public health to 1 grant holder and 11 partnering schools of public health. The last number, which is other partners, which is a new group, it's a little high because there's a lot of redundancy in there. For example, if GWEP A collaborated with GWEP B and GWEP B collaborated with the A, that's actually 2, whereas in fact it's 1 partnership, but it's reported as 2 because everybody reports their own partnerships. But what this shows us is that what the GWEPs have discovered as they progress through their cohort is that they not only needed academic primary care and community-based organizations to collaborate with, but other government organizations, other foundations, professional organizations, including at least 2 states of Department of Public Health. I know that number is rising, and I haven't gotten around to finishing up my data collection just yet, but I can assure you that there are a lot more departments of public health in that last group now than we ever thought we were going to be doing, and we're very happy to have that happen. Next slide. Not exactly. So the bad news is that we're in the last year of our current GWEP funding. The good news is that we've just released a notice of funding opportunity for 2024, which means that people who are looking to apply for a GWEP should be getting that information out. I think that that link has now just been put into the chat, where you can go. We of course do not have money yet, appropriations for 2024, but we do, if there is going to be funding available, anticipate that we will have at least 43 applications funded. So this is your opportunity to either be leading one of those or to be involved in one that's local in your state. Most of our programs tend to be statewide. Some of them are regional. If you wanted to think seriously about who might be applying in your state and talking with them to develop your own partnership list, this is the time that we recommend that you do that. Just a reminder, yes, schools of public health are eligible entities, and departments of health are eligible to be working partners with the GWEPs. So I think that's my last slide, and which means it's time for Lisa.
Great, thank you very much. Well, hello, my name is Dr. Lisa McGuire, and I'm lead of CDC's Alzheimer's Disease Science and Communications team. We'll go to the next slide. So here's my outline for what I'm planning on talking with you about today, but I always like to put a face with what we're talking about. So we're all geriatric workforce, and so my mom has come to join us today. So she died in March of Alzheimer's disease. This was a really, really good day for her in this photo. And this is about November of 2022. So I just want us to think about, when we're talking about geriatric workforce, as the geriatric workforce, please have the faces of all of our loved ones in your mind as you're engaging in your work. Because I think it's sometimes, especially those of us who are more academic, tend to be theoretical, and we need to remember the faces of the people that we are working with and serving. Next slide, please. So a little bit of scope of the epidemic. So I'm just going to kick off some of the background statistics here. So we know the scope of Alzheimer's, it's increasing. Alzheimer's Association fact and figures say we're approaching 7 million adults. We know that it increases with age. The likelihood that somebody will have Alzheimer's, we know that the majority of people who do have Alzheimer's are women. And this is the part that I think most of us need to remember, that about 65% of people with Alzheimer's are living in a community setting. Many times, or at least when I talk to groups, they just make the assumption that people with Alzheimer's and related dementias are living in some type of assisted living or skilled nursing. And maybe there will be at some point, those folks might live there, but not initially. The folks that keep me up at night is the 26% of people who do have Alzheimer's and dementia and who are living alone. I know with your patient populations, these are people that you see and you encounter. And I know many of you, they also keep you awake at night being concerned about them. We know that about 1 in 3 older adults dies with Alzheimer's disease or some other type of dementia. So the point that I want us to think about here, we're all geriatric workforce folks. We know this, but just keep in mind, that the majority of people with Alzheimer's are in a community setting, and really do think about those who are living alone too, and might be falling below some of the safety nets that we have available. Next slide, please. So at CDC, we have 2 different public health initiatives that we operate related to brain health. The first is the Healthy Brain Initiative, which started in 2005. And this tends to be really a national level. And I'll talk to you about some of the things that we do and the tools and resources that we have available for you to utilize. But the whole purpose of this Healthy Brain Initiative in 2005, and we've been working very diligently at it, is trying to advance brain health and really get public health to recognize that brain health is an important part of public health, and that public health does have a role in advancing or thinking about brain health. Then in 2018, BOLD was signed into law. And really the purpose of BOLD, this building our largest dementia infrastructure, is really to create a strong public health infrastructure and really a uniform public health infrastructure for dementia and dementia caregiving. And that is called out explicitly in the legislation. Next slide. So I said I'd tell you a little bit about what our Healthy Brain Initiative does. So the big product that comes out of the Healthy Brain Initiative is our roadmap series. So the largest document, the largest picture you see here is the most recent Healthy Brain Initiative roadmap that was released in June of this year. And so what this does is this is an 18-month process. We get experts from a variety of different fields, from public health to academics to practitioners out in the field. And we really get out also our crystal balls and try to think about what is coming down the pipeline in the next 4 to 5 years within this space. And then we also do some evaluation work and look at what happened or what actions have happened or what successes have occurred from the previous version of the Healthy Brain Initiative roadmap. We launched, as I said before, the Healthy Brain Initiative roadmap for public health in June. It has 24 actions. This next document to the left is our Healthy Brain Initiative roadmap for Indian country. This was a first ever document that was launched in 2019. We are engaged in an update process. So if anyone is interested in that update process, please reach out to me. There's also some public input period right now for that. And I can also help you get in touch with the right people. Next slide. So BOLD. So BOLD, as I said, is pretty recent, 2018, and it charges CDC with 3 very important functions. One is to establish public health centers of excellence. And Dr. Gallagher mentioned that they are one of our BOLD public health centers of excellence, and I'll share with you some of the others in just a moment. The second really important thing that the BOLD funding charges CDC with, or the BOLD legislation, is for CDC to provide funding and support to departments of public health across the U.S. to really build that uniform public health infrastructure. And the legislation even calls out that that uniform public health infrastructure will be built from using the CDC's roadmap series as the foundation. The third, the last but not the least, but a very important thing, is to make sure that CDC is increasing data analysis and that timely reporting of it. So data is great. I'm a data person myself, but the most important thing about data is to have timely data that can be actionable for you and the projects that you're doing to make decisions. Next slide. So in late September, we were able to award our second cohort of BOLD public health programs. So these were awarded to state and local public health programs and also tribal organizations. So you can see the list here. The first cohort consisted of 23 awardees. This cohort is 43, and excited that you're going to hear from a couple of our awardees today as well. Next slide. The next slide illustrates for you our public health centers of excellence through BOLD. So first, we have a public health center of excellence on dementia risk reduction that was awarded to the Alzheimer's Association. We have a second center of excellence on early detection and diagnosis, which was awarded to NYU School of Medicine. And then our host for today, the Public Health Center of Excellence on Dementia Caregiving, awarded to the University of Minnesota. Now, yes, Minnesota is hosting our webinar today and providing wonderful materials and resources for the GWEPs. But I want you to recognize that these other public health centers of excellence have really good materials too. And they are all a resource for you across the nation, whether you're a CDC funded awardee or not. They are a resource to the nation. Next slide. So this is how we work at CDC. So we have, through our Healthy Brain Initiative, we have the section under National Coordinators, which is the Alzheimer's Association and CDC. We fund through the Healthy Brain Initiative population experts. So we funded experts that have access to 3 populations that have the highest prevalence of Alzheimer's disease. So IA Square works with American Indian, Alaska Native peoples. University of Illinois works with adults with Down syndrome and other developmental disabilities. And then Us Against Alzheimer's Brain Health Center on Health Equity focuses on Hispanic and African American adults. And then you saw our subject matter experts with our bold centers of excellence. So the thing that I want you to think about with this Venn diagram-ish over here on the left-hand side is all 3 of these different categories of CDC awards. We all work together. We learn things from each other. So for example, the Center of Excellence, one of our centers of excellence might develop a tool or resource. Then one of our population experts may take that, tailor it, revamp it, and help roll it out to their specific communities. Next slide. So not only do we have that Venn diagram, we are also adding into that our awardees from our state and local and tribal organizations, because they tell us what they need. They tell us what they like, what would be useful to them. And we go back and work on it and try to give them those materials and resources. So it's not that any one of our organizations or any one of our awardees are working in a vacuum. We really are all working together with that toward a collective impact for dementia, brain health, and also caregiving. Next slide. I always like to leave you all with some homework assignments, but I want you to remember, so these homework assignments are pretty simple, but mostly I want you to have these in the back of your mind. Both dementia and caregiving are public health issues. There are points of intervention across the disease progress and the life course. So as public health professionals, we think about primary, secondary, and tertiary prevention. Though those points of intervention are there. Then the second thing that I want you to remember, and this might seem real basic to some of you listening today, but this is a question that I answer almost daily from people. What is normal aging? And what I want us to think about is memory loss that interferes with daily functioning is not a normal part of growing older. And we encourage anybody that's concerned about their memory functioning or that their memory is getting in the way of them living their lives to the way they want to live their lives, please encourage them to talk with our healthcare providers. And I know that the GWEPs are those healthcare providers and making sure that other healthcare providers are trained to have those conversations when patients do come in. Next slide. So please stay connected to CDC. We have a newsletter. We will not bombard you. We will send you information about once a week about latest products and resources. Next slide, please. And then I wanted to give you a brief photo of all the faces in Atlanta that work together to make this impact or this magic happen. Next slide. So thank you very much. And I'll turn it over to our next speaker.
Great. Well, good morning or good afternoon, depending on where you're joining from. Thanks for inviting us to Partner Spotlight from Rhode Island. We are a small but mighty state and excited to share some of our work with you. Do you want to introduce yourself, Faith?
Oh, sure. I don't know if you can see me, but hi, everyone. My name is Faith Helm, and I'm a project manager for the Rhode Island Geriatric Workforce Enhancement Program at the University of Rhode Island.
Great. And I'm Victoria and oversee an Alzheimer's program at the Department of Health. And we did receive the BOLD funding from the first cohort that Lisa had mentioned. And we're excited to have received component 2, which essentially means 5 full years of implementation in this next cycle. So with that, we wanted to kick off our presentation just talking about where the synergies lie between the Department of Health and the Geriatric Workforce Enhancement Program. So you see our 2 kind of overarching goals on the screen for the GWEP. You know, it's a lot of what's already been mentioned in terms of training and other sort of capacities. And I kept our goal simple at the health department, which is to address dementia through a public health approach, which can mean a lot of different things. And for some, I think kind of integrating brain health into public health is a newer concept, but a lot of opportunity for us to have some really strong impact in our state. And I stole some of the goals from the Healthy Brain Initiative roadmap that Dr. McGuire mentioned, in noting that these goals, the P2, P3, W1, these come right from the roadmap and are definitely shared between certainly the health department, as we're charged in implementing some of these goals from the roadmap, but also the GWEP. And so just kind of pinpointing some of those areas within the roadmap that sort of matter to both agencies, and both agencies have the capacity to really do some implementation on all three of those goals, and probably more from the roadmap itself. Next slide, please. So we wanted to tell you a little bit about what we do, how we partner together. We have various work groups that we convene. The GWEP has an advisory board and schedules regular retreats that we attend. The health department has convened a quality improvement collaborative, which is a group of all different types of professionals. The GWEP integrated into that group that has really launched a quality improvement project that we'll talk a little bit more about in just a minute. And then the GWEP also hosts an ECHO work group, a hub team that I sit on to sort of help to deliver and develop Project ECHOs. So Faith, I think we'll talk about the ECHO, and then I'll mention phase 2.
Sounds great. Thanks, Victoria. So before I talk a little bit about our Rhode Island Geriatrics ECHO, which Victoria is a part of, I'm just going to share a brief description of what Project ECHO is for those who might not be familiar with it. So Project ECHO is extension for community healthcare outcomes. It's a virtual case-based learning community, which brings together interdisciplinary teams or hubs and community-based partners, or SPUGs, spokes via Zoom, using an all teach, all learn model approach. So our team for our Geriatrics ECHO is an interdisciplinary team of experts from medicine, nursing, pharmacy, and social work, and they participate in all of our Project ECHOs. And then the spoke sites are our participants or participating sites, and in the past have included primary care, long-term care, nursing homes, skilled nursing, etc. Our Project ECHOs are typically scheduled for 60 minutes, and they include a 15 to 20-minute didactic by a subject matter expert. That is followed by a 5 to 10-minute case presentation, which is presented by one of our spoke sites and typically aligns with that didactic presentation. And then that's followed by a 20 to 30-minute case discussion among all participants. So subject matters, the hub team and spoke sites, and it really creates a virtual community of peers sharing support and recommendations. And so as you can see, Project ECHO is really a great vehicle for building a community practice, and it's uniquely able to bridge gaps between professions and span boundaries between different systems, organizations, and agencies. And in fact, many GWEPs actually implement the Project ECHO model as a way of training their workforce. So with our Project ECHO, we called our Project ECHO series Approach to Dementia Care, a building block to age-friendly health systems. And as Victoria mentioned, she sits on our ECHO work group, which also includes other members from our GWEP team, Victoria in the Department of Health, Health-Centric Advisors, which is our quality improvement organization, and they are our ECHO hub site, and then CTC Rhode Island, which is one of our primary care partners. And in terms of the planning for our ECHO series, we really work together, right from start to finish, developing the curriculum, identifying subject matter experts, recruitment, retention. We developed an evaluation tool together, CME, CE applications, and project follow-up. And our Project ECHO series was actually quite successful. We held 6 biweekly sessions. We averaged over 25 people per session, so we had some great retention. Total attendance of 160, and 48 of those were unique attendees, and they were from a variety of disciplines, including medicine, nursing, pharmacy, social work, OT, we had some community health workers. So we had a great variety and great teams that participated in our ECHO series. And then we had, we enrolled over 20 spoke sites. And again, some of those spoke sites included primary care, long-term care, nursing home, and skilled nursing. And then once that Project ECHO series ended, we continued to collaborate with the Department of Health to kind of launch phase 2 and encourage practices that participated in our geriatrics ECHO series to apply for the next phase, which Victoria is going to talk about.
Thanks, Faith. And I'll just say that the ECHO was a really perfect opportunity for us at the health department to sort of meet some of our objectives around providing education to healthcare professionals and primary care sites as well. And it already existed, so there was no reason to reinvent the wheel. I think there was just a really wonderful opportunity to integrate with something that was already in place. And we sort of leveraged the ECHO series and thought, why don't we take, sort of the learning objectives that people are being subject to in the ECHO and think through how to actually move towards an implementation of the things that they're learning. So we took phase 2, we sort of co-developed this opportunity with the Care Transformation Collaborative of Rhode Island. And we recruited 5 primary care practices to participate in a 6-month quality improvement project. They're about halfway through right now. That helps them to implement the 4Ms of age-friendly care, the Institute for Healthcare Improvement 4Ms, and a caregiver measure, which is a MIPS quality measure that focuses on identifying dementia caregivers, providing education to them, and referring them to a community resource. So again, leveraging some of the great work that was already happening through the ECHO series, and then sort of recruiting folks to participate in this phase 2 QI portion, which really put sort of the learnings into practice and really started implementing the 4Ms in primary care sites. So as I mentioned, they're about midway through. There is a representative from the GWEP that sits as a practice facilitator who meets regularly with the primary care sites and sort of helps them think through workflow changes, EMR template building, data collection, and other sort of reporting to help them meet the requirements of implementing the 4Ms and that caregiver measure. And on the screen, we've provided a couple of links to the age-friendly care model, as well as the MIPS measure on dementia caregiving. Next slide.
Great, thanks, Victoria. So in terms of our Project ECHO series and in partnership with the Department of Health, we felt it was really a nice example of a mutually beneficial relationship where both of the partners were able to bring some valuable things to the table. And as Victoria just mentioned, we had a Project ECHO series in existence over the last 3.5 years or so. We were running series every fall and spring. And we, at the same time, as a GWEP, were looking to develop a curriculum for our spring series related to dementia. So it's kind of a win-win for both of us. We were also able to facilitate connections to subject matter experts. Our GWEP has worked with a lot of content experts over the years in many of our educational programs, including Project ECHO. We also were able to leverage existing frameworks, including the age-friendly 4M framework for the delivery of this Project ECHO, which obviously aligned nicely. And we've been using that 4M framework for many of our Project ECHOs and other educational programs. And then again, we were also able to utilize existing structure of our interdisciplinary hub team, which has been with us for the last 3.5 years. And then we also were able to enlist the support of our quality improvement organization, Health-Centric Advisors. And Health-Centric Advisors is the actual hub site. And they assist us with the technical assistance and data collection. And since we had several Project ECHO series prior, we were able to kind of leverage those recruitment efforts. And, we already had a small established audience of spoke sites who had enrolled in some of our earlier series. And then fortunately, we had some funding from HRSA, and that supported our hub team and content experts, as well as the technical assistance that was sent to our quality improvement organization. Right.
And on the flip side of that, a huge sort of deliverable on the health department side is to really engage with new partners statewide. And so this gave us an opportunity to develop that partnership with the GWEP and the University of Rhode Island. We helped to assist with the recruitment and identification of target audiences. So yes, they had an existing kind of spoke sites from their earlier series, but we were able to sort of be that connector to other interested audiences that might want to participate in the ECHO and then further their participation in the Quality Improvement Project. We talk a lot about FOMO, fear of missing out. The GWEP alone is strong for sure, but the GWEP plus the health department, plus our other sort of partners on the hub team, I think we sort of bring this fear of missing out opportunity to some of the primary care sites that would be maybe more interested in participating through this kind of partnership than just partnering with the GWEP alone. So it was a nice kind of added strength in partnership. And then similarly to the HRSA funding, we have the BOLD funding, which is really helpful in engaging with some of our partner sites. And we were also able to get the attention of one of our health plans in Rhode Island, United Healthcare, that also provided funding to support this project. And with that funding, we were able to provide stipends to the participants of the ECHO series, as well as the Quality Improvement Initiative. Next slide, please.
Great. So in terms of future plans, we just started to reconvene our work group meetings, and we're working to plan a 4 to 6 session Project ECHO series that we're hoping to hold this spring. We're obviously working together with the Department of Health, and we're also hoping that the 4 sites that are involved in the phase 2 will participate in this ongoing series. And based upon feedback from those spoke sites and others, the series will focus on identifying and implementing community clinical linkages to support the needs of caregivers. And we're hoping to educate providers on how to recognize and help meet the needs of caregivers who are caring with individuals with dementia.
And we also intend to host another quality improvement cohort following the spring 2024 ECHO series. I think it's a really wonderful way to jump from learning and education to then actually implementation through sort of a organized quality improvement program that provides sort of project management and sort of PDSA cycles and some oversight of that work. So of course, Faith and I are always happy to talk more about ECHO and the QI project that we have going on, but we wanted to provide just a few other ideas for ways that GWEPs and departments of health could possibly collaborate, including the development of CEU and CME opportunities. Faith and her team at the GWEP are consistently creating these types of opportunities, and we promote them through the Department of Health website. We're also working together on another curriculum development committee that is building some dementia-specific specialty training to meet some of the needs of our BOLD grant. And then we have been engaging together as we build out and create an implementation plan of our state plan on Alzheimer's disease and related dementias, and really focusing on how to sustain those efforts. And naturally, we would be submitting letters of support for any future funding opportunity so that we can continue our partnership. Next slide, please. I think in any partnership, there's keys to success. These are ours. Happy to talk more about this maybe in the Q&A section, but wanted to give you a sense of how this partnership has been so helpful. And I think our last slide are just some acknowledgements. So we will pass it to the next speakers. Thank you.
Thank you.
Good afternoon. Hi, everyone. My name is Elizabeth Head. I'm the Deputy Director for Injury Prevention at the Georgia Department of Public Health. I'll turn it over to my colleague, Ted.
Hey, Ted Johnson here. I'm the Program Director for Georgia GEAR, which is Emory University's GWEP. And Liz and I are going to go back and forth. And so thanks for push pinning each of us. And so Liz, here's the next slide and then back to me.
Yep. So in Georgia, we're a 159 county decentralized state. And with that large of a state and that many things to keep track of, generally, we just try to say to one another, let's do this, and we figure it out as we go. And that's going to be our motto today, too, as we do this. Next slide, please.
So one of the things about applying to funding from HRSA through a cooperative agreement is the agreement to cooperate. And that's been a really important principle for our work with HRSA. We're very proud of the work that we've done and proud of the opportunity to do this and to be featured today. One of the things that we designed in our 2019 to 2024 Georgia GEAR application was addressing HRSA's requirement to, you will do this and this and this and this and this and this and this. And if you look at program objective number 5, there's a lot of things to do. And there's not one person who could do any one of these things well. And so part of our humility and acknowledgement and request for partnership is to actually find other people who are going to do some of these things that we're not quite as linked to, despite being involved in geriatrics and gerontology for 20 years. There are things that other people do better. Let's go to the next slide. So I wanted to highlight 15 of our different partners. And if Rhode Island was a sibling relationship between BOLD and GWEP, then here in Georgia, we would call ours a cousin relationship, because we're part of the same family, we have shared objectives, and we align with some of the same shared partners. And so in Georgia GWEPs, in Georgia GEAR's application for the 2019-2024 funding, we were thinking about how are we going to do all this? And it was really through partnership. And so I'm going to just call out some of our partners here. Alter, led by Dr. Fayron Epps, dementia-friendly villages, faith communities, and Black churches that started in Georgia and it's expanding across the country. Georgia MemoryNet, Department of Human Services funded Emory Alzheimer's Disease Research Center, offering technical advisory capacities out in 7 different areas of Georgia, as well as partnerships with departments of public health in many of our 159 counties, second only to Texas in terms of number of counties. Dad's Garage is an improvisation comedy troupe that is affiliated with Georgia State University's Dr. Candace Kemp, and we are using improv-influenced dementia communication strategies in order for caregivers and students and health professions to use the yes and to be present with people who are going through various stages of dementia. Atlanta Medical Association is a historic African-American group of physicians, dentists, and chiropractors that's over 120 years old. They are a great partner for our outreach in African-American communities about Alzheimer's disease. An integrated memory care clinic led by Dr. Carolyn Clevenger, one of those exemplars of designed for purpose care. I'm proud to be a supporting physician for that, and they're sort of recognized as one of those guide type programs. Next slide.
So conversely, here in Georgia, we are a BOLD recipient, as you saw from Lisa McGuire's slides, and that has come down as a result of that 2018 BOLD infrastructure for Alzheimer's disease. Really, we took this and wanted to take that next step in partnership across our state. We've had a lot of informal partnerships for a very long time. We've taken a lot of notes at meetings, but this finally gave us some funding. Next slide. So for our 2023 to 2028 BOLD 2 component, we're really focusing in on continuing to increase collaboration across all of our partners. It's really well outlined in our Georgia Alzheimer's and Related Dementia State Plan, or GARD State Plan. And there's an emphasis on really training our public health workers up in very specific ways. We partner with a lot of the same partners that TED does in order to make that happen. All of our risk reduction efforts, we have regular meetings with our partners to make sure that we are doing complementary efforts, even where they might overlap. We do so in different parts of our state, and that allows us, frankly, to have better coverage across our entire state. And of course, for everything that we do, our emphasis for BOLD is really on those with a high burden of Alzheimer's disease and related dementia in rural populations. Next slide.
Liz and I are going to split this side. In addition to all the partners, we have individuals that are shared aunts and uncles. Ken Hepburn in the Savvy Caregiver program, Rick Goodman, who is really known for his chronic medical conditions, multimorbidity work, but does intersect with dementia care. And probably our favorite aunt, Liz, is Rebecca McIntosh. If you work in Georgia and aging, Rebecca McIntosh is likely one of your favorite people as well. She was in 2010 to 2015 the associate director for our geriatric education center located in Atlanta, and did a lot of work with Georgia Memory Net as their lead administrator for their launch, and is now the lead for cognitive neurology as the administrator. So here's some of the shared partners, and here's what we do with each of these partners. So Georgia Memory Net, we provide support for the primary care advisory boards. We do education and outreach through our seminar series, monthly telemedicine series, Georgia Memory Net Insights, or GM Insights. With Alter, we help with program staffing, marketing, and program expansion beyond Georgia. With the integrated memory care, we do marketing work. We work with them on our MIPS measures, including advanced care planning in falls, and clinical practice support. And with GUARD, the collaborative, we are connected to them, but certainly more loosely than Liz will mention in terms of her partners. Liz?
Yeah, absolutely. So from our perspective, we work with Georgia Memory Net specifically on some telehealth tablet projects. And that is allowing us to bring public health into the fold of getting towards diagnosis. And that's going to require some training that our friends at IMC are going to be willing to help us with, which is very exciting. Everyone that can works hard to support Alter in our state, because that allows us to provide our rural caregivers with yet another option. Folks are so hungry for information, for resources, for connections. Helping and supporting Alter to get into the rural parts of our state has been a really fantastic investment for all of us, even when we're doing it in slightly different ways. And of course, for us, GUARD, our GUARD state plan is a living document, and we've worked really hard to keep it being in that sort of way. So we work hard to make sure that that larger umbrella is meeting the needs of the work that's happening, as well as guiding us for what the next steps might be in all of that work. Next slide. So for all of us specific to BOLD collaborative activities, we've got sort of three big buckets. And Ted had been mentioning Rebecca McIntosh. She and I have spent many hours on phone calls. We like to call it scheming away at the different things that we're going to do and how we're going to do it. And really having that champion across both of our respective organizations has allowed us to thrive and continue on parallel and complementary paths. And across education and training, that is things as simple as promoting each other's events, making sure that, did you know Rebecca? Do you know Carolyn Clevenger? Because everyone should know those folks. Do you know our caregiver advocates like Sharon Hall, who's famous for Do Not Diagnose an Adios? We try to provide SME support at the state level health department for all of our local health departments that are just getting into all of this. And often that is by helping them write local grants so that they can begin this work in a way that makes sense for them, and making sure that our state level partners are aware so that they can support those new grantees in some fun and interesting ways. And of course, through everything, we're looking to implement those evidence-based programs and support one another across the implementation of those programs. Sometimes we're sending out a flyer for recruitment. Sometimes we're talking through evaluation challenges across our different levels of expertise, but we try to have those phone calls and in-person meetings now that we can do so in productive ways. Nice slide. Next.
Just to finish this up, one of my colleagues that works in a couple of different areas and with partner groups, we sometimes get so involved with partners in coordinating that sometimes it just feels like it's easier to do it yourself. And the answer is it's just not. And so whenever we get frustrated with, can we get everybody on the same page? We just say this mantra because the work is so important, and we go forward. Hey, thanks so much for featuring us down here in Georgia.
Thank you.
Wonderful. What a great group of presentations and panelists. You've seen some live examples of how both GWEPs and departments of health and others can collaborate to really, I would almost argue, serve as a force multiplier of the work that's being done, and to really elevate each other's initiatives as well. And the first question I have will actually be for you, Dr. Tomosa. And one thing I wanted to reflect on after listening to Dr. Tomosa's very informative set of slides was, and I'm not sure if this was mentioned, if it was, I apologize, is one thing about the GWEPs is they have a broad mandate in terms of geriatrics in general, a focus on geriatrics in general, in terms of workforce, education, engagement, et cetera. However, and much to the credit, I would argue, of HRSA, a significant component or percentage of the funds for GWEPs is actually dedicated to engagement in the dementia space. I want to say it's roughly a quarter, maybe a little bit more. And so that is where I would argue, and I think many would agree, where there are these natural points of interface between BOLD recipients, certainly our national center, and GWEPs as well. And so with that, Nina, we have a question here from Jennifer, Jennifer Queen. Pardon me if I didn't pronounce the last name correctly, but Jennifer is asking, where's the best place to look for information on the schools of public health, and are they geriatric exclusive? So I think this is a response to that very helpful slide you put up of showing the number of schools of public health who were involved in GWEPs.
Right, exactly. Excellent question. Thank you very much. No, schools of public health. I'm not in a school of public health. I've never been in one, but I think it's safe to say that schools of public health have many mandates, geriatrics being one. And I want to just back up, if I might, and remind everybody, or to inform them if they didn't know. Yes, GWEPs do have a broad mandate of what is required, but we require that they be, whatever those things are, that they be done in the context of local need. And of course, as you say, approximately, it's a little bit less than 25% of our funds are mandated to go towards dementia education and training and services. But many of our GWEPs actually do more than 25%. So we do have a strong need that has been shown by many of our grantees for assistance in geriatrics. And I think everybody needs to come to the table. Geriatrics really is a team sport, and everybody on the team is going to bring something new to the table. So I certainly encourage every school of public health that can possibly get involved to do so, even if it's not a mandate or a major component. We take partners who do big things. We take partners who do little things, and all those things add up.
Wonderful. Thank you, Dr. Tomosa. And I guess I can address that. Jennifer actually raised a really important question. Me being in a school of public health, and I think my representation would be included as one of those schools of public health who've been involved with GWEPs, this current cohort. You know, and Lisa, you may want to add something to this too. Many schools of public health don't necessarily focus or perhaps even have a core point of emphasis on aging. The School of Public Health at Minnesota is somewhat unique. Bob Kane, Dr. Kane, who was a mentor of mine and a colleague for many years, my predecessor, along with his partner, Rosalie Kane, very much championed the founding of what was the Center on Aging here in the School of Public Health at the University of Minnesota. But if one looks at all the schools of public health across the U.S., centers on aging generally are not in schools of public health. They tend to be located in other areas. Now, I think with BOLD and I think with CDC's focus on dementia, hopefully that's starting to change, where issues related to aging and dementia are indeed seen as issues of public health import. And Dr. McGuire, I don't know if you wanted to add to that.
I mean, I think when you've seen one school of public health, it's kind of like any department of X. It varies across the US, but my knowledge and experience is more that they tend to be more cross-cutting issues as opposed to population specific or age group specific. But a couple of things that I want to point out that CDC has done in collaboration with the Alzheimer's Association, because there isn't a lot, or in many places, a lot of education on the issues that we're all very interested in, dementia, caregiving, etc. The Alzheimer's Association has worked to develop a series of course materials. They're designed for undergraduate schools of public health, but based on our evaluation feedback, they're used much more broadly. People use them for their GERO 101 classes. They get used for community meetings. But I would encourage you to look at our website, cdc.gov/aging. There's a general one on dementia that is being actually currently updated. There's a recent one that the Alzheimer's Association, I think this just got put in chat, developed in collaboration with the Bold Center of Excellence on Dementia Caregiving on caregiving education for public health professionals and students of public health. And then there's another course that was recently released this year on equity. So those are all free, publicly available, downloadable. The last two I mentioned are actually in like fancy LMS systems. So if you want to give it to an assignment to your class, you can, have them print out a certificate and have proof that they did it. The original one was a series of PowerPoints with an instructor guide, but that will be transitioning over to an LMS.
Right.
Both the courses I mentioned, the latter ones, the new ones, they also have instructor guides as well.
Thank you, everyone. And of course, when I make a statement like that, people are starting to mention in Q&A other institutions that have schools of public health or have centers or institutes on aging schools of public health. I'd be remiss not to mention them. University of, I believe, South Carolina, USC was mentioned in the Q&A, my apologies, but certainly Johns Hopkins, who I have many colleagues there. Good point that someone raised that. University of Georgia has one as well. So I definitely want to acknowledge there are indeed many, many great aging scholars located in schools of public health across the US. So thank you for that clarification, everyone. I want to end with one last question since we more or less are at time. And Dr. Johnson, I'm really glad you're here, Ted. This was a really great question provided in the Q&A, which was this. Could you clarify what is meant by normal in terms of brain functioning within the human population? Do you mean that within the human population and across the life course and context, that brain functioning varies, but not having the supports needed to do what one wants or needs to do is not normal? Also, please, could you clarify whether people with Alzheimer's have a healthy brain within the CDC frame? So I think this is a response to some of Dr. McGuire's slides, but Ted, I thought I'd start with you in terms of addressing it. And if we have some time, maybe Lisa could address it too.
Thanks, Joe. I appreciate it. This is a tough question. It just disappeared. Can it go back for a second so I could look at it while I address it?
You know what? I just clicked the button. And
No worries. So it's like, and the question's gone. So
I know, I'm sorry.
Thoughts. One is that I thought that Dr. McGuire teed up the appropriate recognition that if memory and function is impaired, if memory is impaired and function is impaired, then that's not normal aging. That's not a consequence of normal aging. And so I think that there's this normal versus disease state. And I think that it's probably best for us to consider that a disease state, and that would not, it's very difficult to call people unsuccessful aging. And it's also very difficult to call people unhealthy in their brain. As a clinician, let me go back to maybe something that gives me some footing for what I'm about to say. And that's that when I'm doing cognitive testing in clinic, the normal framework that some clinicians have and some patients have is that you're about to tell me everything that I can't do. And I think that that's probably a wrong framework, where we should be thinking about what would be hazardous for folks to do and what could emphasize their maximum function in their lives and in their families. So I hope that's helpful. Thanks, Joe.
Wonderful. And I don't know, Lisa, if you wanted to make a final comment here before. I think Dr. Johnson did a great job.
No, I mean, I think that was a great question, and it's one that we struggle with coming up with between what is expected as, what could be considered within the range of normality. My husband, since I've known him in our 20s, can never keep track of a set of car keys. If that now is interpreted as pathological for him, he's going to be in big trouble. But he just has this, he just throws them down and then doesn't pay attention to where he throws them down. So, it's really looking at a person and looking at them over time and looking at the changes. So that's where I think, people who know the person and who are informed about their normal patterns of behavior. And I mean, I'm bad with names. My husband can't keep track of car keys. And that's the way we've just always been. But I remember faces.
Yep,
Yeah.
yep. All right. Well, thank you everyone for joining us here today. Again, as a reminder, please do complete a survey providing us with feedback on this superb webinar today. I'm biased, obviously, but I think it was wonderful. We also will be sending you slides, a link to the recording, as well as the chat. I think someone had a great question or comment about, can you please download the chat? Because as you can see, lots of great resources being shared there, and we will make sure to save that and share that with you too. And then finally, all these materials will be made available on our website, bolddementiacaregiving.org. Thank you to the wonderful panelists here today, Dr. Tomosa, Dr. McGuire, the great teams that are really exemplars of partnerships, both at Georgia and Rhode Island. And a big thanks to Elma Johnson and Maya Koski for their wonderful coordination. Have a great rest of the day, everyone. Please do reach out if there's anything else we can ever do. Thanks again.